Good afternoon, good morning, and welcome to our webinar today. My name is Terry Camacho Gonzalez, and I am the project director for the Technical Assistance, the Traumatic Brain Injury Technical Assistance and Resource Center. The TBI TARC is funded by the Administration for Community Living and is managed by Human Services Research Institute, HSRI, in partnership with the National Association of State Head Injury Administrators, or NASHA. This webinar is free and open to the public. Before we start, just want to go over a few things. Participants will be in listen-only mode during the webinar, so please use the chat feature in Zoom to post questions and communicate with the host. This webinar will be live captioned in English and live interpreted in Spanish. Live English captions can be accessed by clicking the CC button at the bottom of your Zoom screen. Este seminario web se subtitulará en vivo en inglés y español. Se puede acceder a la interpretación en español en vivo haciendo clic en el botón Interpretation en la parte inferior de la pantalla de Zoom, el icono del mundo. Una vez en el canal de español, por favor, silencie su audio original. If you use ASL interpretation, we encourage you to join on a desktop device, as your mobile device may only show the active speaker. This live webinar includes polls and evaluation questions, so please be prepared to interact during the polling times. Here's a little bit about the TBI TARC. We, as I noted, we're funded by the Administration for Community Living, and we help the TBI State Partnership Program grantees promote access to integrated, coordinated services and supports for people who have sustained a TBI, their families, and their caregivers. We also support other people by providing resources to non-grantee states, people affected by brain injury, policymakers, and providers. Here is the key TBI TARC team. You will later meet my colleagues Maria Crawley and Judy Detmer from NASHA, and we also have Ben Sahaki and Vivian Solomon who are available during the webinar. Before we get started, we want to know who is joining us on the webinar and what roles you self-identify.
Terry?
It's not moving.
You. It's not advancing.
Huh.
There we go.
Yeah. That's very interesting. Okay. Sorry about that. So we want to start off by doing a poll. Actually, I should go. And the poll is it's right now, you can see it on the screen. You can select more than one role that you self-identify as. The first is a person with a TBI or other disability, a family member or a friend of a person with a TBI or other disability, self-advocate, peer specialist, peer mentor, and as I said, you could choose more than one, social worker, counselor, care manager, researcher, analyst, a service provider organization employee, or a government employee. And we usually wait around when we reach the 80%, so we're almost there. We just want to give people a chance to provide this gives you enough time to select what roles you identify with. And this is helpful for us to know who is joining us, and also for the speaker to know what type of participants are on the webinar. And it looks about 42% right now and we're almost at 80%, are social workers, counselors, care manager, 25% service provider organization. We have about 8% people with a traumatic brain injury or some other disability family members, and 50% are government employee. So I'm going to stop sharing now. I'm going to now have my colleague Maria Crawley get on and introduce our speaker for the presentation. Thank you, and I'll be back at the end to do a second poll and close us off.
Thank you, Terry. If you are here for cognitive impairment and substance use disorder treatment, Neurologic Informed Care, you're in the right webinar. And I do have the pleasure of introducing today's presenter. John D. Corrigan is a professor in the Department of Physical Medicine and Rehabilitation at Ohio State University and director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. For the past 40 years, he has treated and studied long-term outcomes of individuals with traumatic brain injury. He is editor-in-chief of the Journal of Head Trauma Rehabilitation and has been the project investigator and co-project investigator for Ohio's regional TBI model system since 1997. The Ohio Brain Injury, which he directs, is the designated lead agency in the state of Ohio for policy and planning related to individuals living with brain injury, and he's a widely known expert in this field. As you can see, he's been involved in a number of committees and organizations related to brain injury, including the CDC, the Veterans Administration, Department of Defense, and the CARF board. So without further ado, I would love for Dr. Corrigan to come on and talk to you about a recently led effort that involves inclusion of the term neurologic informed care into the most recent ASAM guidelines. Welcome.
Thank you very much, Maria, and it's a real pleasure to be here. I'm excited about sharing this information. So let me get my slides going here. And we will share and present. Excellent. And just got to, there we go. Great. So I am pleased to be invited to talk about some new developments in terms of standards and expectations in terms of in substance use disorder treatment, or what we call neurologic informed care. I do have some disclosures. I have funding from several federal sources. With Jennifer Bogner, I developed the Ohio State University TBI identification method, which is mentioned, and Ohio State University, but not myself, benefit from the OSU TBID's inclusion in the online brain injury screening and support system, which I will also be mentioning. Objectives. So when we finish today, I hope you'll be able to describe, essentially the intent of the new ASAM criteria related to cognitive impairment. Maybe be able to list 3 to 5 common sources of cognitive impairment and identify 2 or 3 cognitive impairments that may require accommodations to improve substance use disorder treatment. So the American Society of Addiction Medicine has been promulgating criteria for how substance use disorder treatment should be delivered for a number of years. And it really, in many ways, is the industry lead in terms of defining levels of care and the components of those levels of care. They just redid the criteria. The 4th edition came out this past December. And in it, for the first time, is a chapter on cognitive impairment. And in the introduction in that chapter, it indicates that cognitive impairment is a complication in substance use disorder treatment. It exacerbates barriers to care, complicates the clinical management, and further limits treatment outcomes. And as a result of that complication, what is described is an approach that has been termed neurologic informed care. And that term, that phrase, was intentionally chosen to parallel trauma-informed care because there are many parallels to how we are thinking it should be integrated into substance use disorder treatment. Neurologic informed care addresses cognitive weaknesses, whether they are subtle or not. And it is particularly, by the way, those subtle weaknesses that are often misinterpreted by clinicians. And that will be a major theme of my remarks today. Neurologic informed care it results when a clinical staff understand that this is an issue in, it turns out, many of the people that you treat, and have the skills to adapt treatment to accommodate these kinds of impairments. It's not a specific substance use disorder treatment modality. It's instead a set of knowledge and skills that are applied whatever treatment modality a clinician is engaging a client in. So kind of the roots of it come from the DSM-5 and some changes in how cognitive impairment was conceptualized in the DSM, that version of the DSM. In the past, we always talked about delirium, which is represented here in this oval on the left, and dementia, both of which are states of cognitive impairment where there is enough so that one is typically confused. We only talked about those two kinds of cognitive impairment. But in the DSM-5, dementia, we still talk about delirium, but dementia was termed a major neurocognitive disorder. And then a new category represented in this oval in the bottom of mild neurocognitive disorder was added. And this new category really recognizes that there is a lot of impairment, relative weaknesses in thinking skills that is not delirium and is not full-fledged dementia. So neurocognitive disorders, so in the DSM, they are distinguished from intellectual and developmental disabilities. I'm not, we are going to be talking about cognitive impairment, not neurocognitive disorders. So the diagnostic specificity is not going to be essential here. And in general, what I would say in real life treatment, what's causing this cognitive impairment is not so important as that it's there functionally. And then, of course, as a clinician, what can you do to mitigate the effects of that cognitive impairment? Major neurocognitive disorders, or the dementias and delirium, would be limiting a person's independence. Well, what's unique about the mild neurocognitive disorders is that a person remains independent. They remain functional, but it affects essentially the efficiency with which they can engage in cognitive tasks. And we're going to talk more about that because that's a good thing. It's a good thing that they remain independent. But on the other hand, I think it tends to mask our recognition of its presence. There are a variety of causes. We will talk a little bit about that. And despite there being, this major and mild categories, cognitive impairment exists along a continuum. And not only is it along a continuum, it's along a continuum within specific domains. And so a person may vary. There may be certain domains of cognition where they have weaknesses and others where they don't. And again, we should always be thinking of this as a continuum. So let's take a closer look at these domains. So what's on the screen now is a table with 3 columns showing the cognitive domains on the far left, and then the effects, the symptoms, or the manifestation of major neurocognitive disorder by domain in the center column, and then the far right column is mild neurocognitive disorders and what symptoms or manifestation we'd expect. Down the middle, what you see there are a lot of inability to do something altogether. So that's that losing one's independence. But what I want to focus on is in the mild neurocognitive disorder. So I'm going to just collapse this table into just the 2 columns. So now we're just looking at the mild neurocognitive disorders. And as you read some of these descriptions, being less efficient when in the area of complex attention, being less efficient, but still functional, tiring more easily. Under executive abilities, it requires more effort to do something that the next person, do the same thing that the next person is doing. You may have more difficulty with multitasking. I'm not going to go through all of these, but the point is that the extent to which the impairment manifests, that you would see it in treatment, can vary by things that are unrelated to the kind of underlying neurologic disorder. That it could vary because the person had a bad night's sleep. It could vary because it's late afternoon and been in group for all morning. It could vary because the environment where somebody is, where the person is distracting and is loud. It could vary because the thing that you're working on is of greater interest or less interest. And so that variability is sometimes misinterpreted as meaning it's under a person's control. And that's where we start down kind of what I think is the wrong road of misinterpreting some of these mild neurocognitive disorders as being intentional or psychological or a reflection of a person's motivation rather than being the result of a neurologic disorder. So just to make that point a little clearer, you know, we've in treatment, we've heard these words. He pays attention to what he wants to pay attention to, or any parent of a child with attention deficit disorder who plays video games has said, why can't he only listen for 10 minutes in class, but can play video games for 2 hours? She's just lazy. He just wants all the attention. She's in her own little world. But all of these conclusions about behavior that a person is seeing imply that it is to some degree under their control or at their discretion. But if indeed it is true that with a complex attention weakness, one will be able to pay attention longer and better to something that is of interest. And if something is of less interest, the attention span will be shorter. For somebody who fatigues from doing cognitive tasks, it can look like they're giving up or not trying when indeed they've worn out. It's not laziness. Somebody who's hyperverbose, who talks too much and is not in tune with social cues, may end up, you know, dominating group and not be aware. It's not attention getting, it's part of a cognitive disorder. And similarly, people who have poor auditory processing for whatever reason often do withdraw because it's just such it takes such effort to stay up with the spoken word or conversation. Yeah, the point here is that we have to be careful when we're making a judgment about the behavior we're seeing in a client who's receiving substance use disorder treatment. And there's a big difference versus can't versus won't. Won't implying that it's willful, that somebody is just choosing not to, while can't reflecting that this is a difficulty that is a result, in this case, of an underlying neurologic condition. So can't versus won't. I know we've all heard this before, but I think it's really critical. And the other thing I would say, and this is based on clinical experience, not empirical. I don't have empirical data behind it, but I did run a substance use disorder treatment for persons with brain injury for 25 years. So I do have a little experience that if you see a behavior and you don't know why it occurred, person missed an appointment, but you start with, oh, don't you want to get better? So implying it was willful, or they chose not to, versus did you remember to set your alarm that morning? You will do very different things if you're wrong to the therapeutic alliance. If you start assuming that it's willful and you're wrong, you can greatly undermine the therapeutic alliance. If it's willful, but you start by thinking maybe they just, forgot to set an alarm, that has other implications, but it doesn't have the same effect on the individual of particularly feeling like you don't get them, that you don't understand where they are. Because indeed, I do want to get better. I just forgot to set my alarm. So can't versus won't, and where we start makes a big difference. A little bit about cognitive impairment, causes of it. There are a number of reversible causes. You can have temporary illness, metabolic disorders, infection, medications can cause it. Of course, during detox, and as well as the transient acquired brain injuries. The persistent causes, we're well aware, include individuals who have intellectual and developmental disabilities, as well as those who have neurodegenerative diseases, including dementia. What we may not be as aware of is all of the sources of acquired brain injuries that can also be a persistent cause, another cause, cognitive impairment that's going to persist. So just a little bit about nomenclature here. Acquired brain injury results when there's been a injury to the brain in some way that it's not hereditary, it's not congenital, meaning with birth, it's not degenerative. The most common are strokes or cerebrovascular accidents, infectious diseases as well. Tumors can cause acquired brain injuries. Anoxia and hypoxia are when there is a denial of oxygen to the brain. And then, of course, the traumatic brain injuries. Now, one thing to know about this list is that the first three there, strokes, infectious diseases, tumors, are generally medically attended to, will be found in a medical record if you have access to it, and a person's aware that they had it, that they, if asked, they'll be able to tell you. But with the anoxic and hypoxic injuries, as well as traumatic brain injury, there are a number that are less pronounced, less serious, that a person may not even realize was an event that could have affected their cognitive functioning, could have affected the brain. So when you're in the area of detection, you're trying to figure out, has somebody had this, have this source? You need to approach anoxia and hypoxia and traumatic brain injury a bit differently than the other acquired brain injuries. Now, traumatic brain injury, its definition is when there's a disruption of brain function caused by an external force. So that's the key with traumatic brain injury. It's the external force that now has caused the disruption in brain function. Like other acquired brain injuries, the effects can be temporary or they can be permanent. And unfortunately, we don't always know where that line is drawn. It's important to know a concussion is a traumatic brain injury for reasons that could take another webinar. The nomenclature we chose in the field, concussion just sounds better to folks, but it is important to know a concussion is a traumatic brain injury. And traumatic brain injuries, as I've implied, vary greatly in severity. And that variation is also part of why I think they are not always, they're not well understood by healthcare and social service professionals. So just as a quickie to, looking at the continuum of severity and how it's defined, if you go from least severe on the left to most severe on the right, on the least severe end, when the external force happens, if it just causes one to be dazed, confused, or have a gap in memory, and I should not say just, because this is still a disruption of brain function, but a person remains conscious, that's the least severe part of the spectrum of severity. If you actually lose consciousness or are knocked out, then you've had a more severe injury. And of course, that varies by particularly how long you're knocked out. And then with coma, on the most severe end of the range, not only are you unconscious, but there are certain reflexive or automatic reactions of the brain that are not occurring. So, we define the severity can be defined by this range of disruption of how the brain is disrupted. Unfortunately, in the field, we chose some nomenclature that is proving not to be as helpful. And that one mistake we made is that we called mild TBI a very large range of injuries, all of those that include dazed, confused, and gap in memory, as well as some of those that result in a loss of consciousness. Moderate TBI then being the rest of that, that's those with loss of consciousness, and severe TBI primarily being those that result in coma. The field is trying to move away from these terms because, for one thing, that while they were meant to describe the initial injury, they are being misinterpreted as an indication of the effect of the injury, and that's a mistake. So we are trying to move away. But for those who aren't in, brain injury wonks or aren't in the brain injury field, there are a couple of benchmarks that are worth noting, so that if you are hearing about somebody's history and you hear that somebody had a traumatic brain injury, you can kind of judge the severity of that. And one of those benchmarks was there loss of consciousness, where you actually knocked out, eyes out, even if it was briefly. Those without it, in general, but not exclusively, will be less severe. While the other benchmark worth knowing is, did that loss of consciousness persist for more than 30 minutes? And those generally will be what we call now moderate and severe traumatic brain injuries. But just those two benchmarks will give you a quick kind of rule of thumb for assessing if somebody said, I've had a traumatic brain injury, knowing just what severity it is. Because what I'd suggest to you, that if I said to you, my name is John and I have had a traumatic brain injury, I've actually told you more by what my name is, because you get some idea perhaps of my gender identity, than I have told you by saying I have had a traumatic brain injury, because that could have been one way down here on this end or one way up here on the other end. And I'm going to just take a breath here to make sure because I am covering a lot of information, I realize that. But let's use those three categories we just looked at to look at prevalence then of lifetime history of traumatic brain injury in the adult population. So this NETBI means the whole spectrum. You had anything from the whole spectrum. TBI with loss of consciousness is just those who the injury resulted in being knocked out or worse. And then this moderate and severe TBI, as we just looked at, was those who were knocked out for more than 30 minutes or including having coma. So we only have a few states where we have population-based data to look at this kind of breakdown. But with the ones we have, there's a kind of emerging convergence that about a third of the adult non-institutionalized population in a state will have had at least one traumatic brain injury of any severity in their lifetime. 1 in 5 will have had one with loss of consciousness, and 1 in 20 will have had a moderate or severe traumatic brain injury. These percentages are higher than anything we've suspected before. Hopefully, the Centers for Disease Control and Prevention is en route to being able to give us some very reliable kind of national estimates. But so far, what their preliminary work is suggesting is that these numbers are not very far off. But what's important here is, it's not the general population that comes for substance use disorder treatment. And in those studies where we've looked at people receiving treatment, these prevalence rates are way higher, doubling with any TBI or TBI with loss of consciousness, and 3 times as the prevalence in terms of having a history of at least one moderate or severe traumatic brain injury. So now this isn't 1 in 20, this is 1 in 5 in your waiting room are likely to have had a history of moderate or severe traumatic brain injury. This picture, by the way, is pretty consistent across other vulnerable populations, whether it's psychiatric inpatients, prisoners, those who are unhoused. We see the same higher rates of histories of traumatic brain injury, and particularly histories of more severe traumatic brain injuries. So why is this? Why is it so common among vulnerable populations? And there's a kind of a pretty simple pathophysiologic explanation for it. It's not simple, but it's straightforward. And that's the conclusion, which is this. And if you maybe took 2 things away from this talk today, this, I hope, could be one of them. And that's that wherever the blow comes to the head, the back, the side, the top, the frontal areas of the brain, including the frontal lobes, are the most likely to be injured in a traumatic brain injury. And the reason for that is that once the head is set into motion, that there's twisting, turning, the brain will move within the cranial vault. And it generally that's okay because there's kind of a gelatinous material there that cushions the brain between it and the skull. There's a leathery material that covers the brain. The inside of the skull, for the most part, is smooth. So some movement, some jiggling is okay. But unfortunately, here in the frontal areas, and this picture is looking down from the top at the skull, in the frontal areas, there are these bony ridges. And when there's enough force that the brain jiggles within the cranial vault, there can be scraping across those bony ridges and causing contusion or bruising in the frontal areas. A second dynamic, and I forgot I put this in here, that so from the beginning, whether we were looking at autopsies that Corville did or later imaging done by Bigler, consecutive cases of persons with traumatic brain injury, you can see that it's particularly focused in the frontal areas. Again, no matter where the blow came to the head. There'll also be bruising in those other places, but in addition, the front gets affected. A second dynamic is that the way the tissue is kind of, I would say, kind of packed into the frontal areas means that if it is set in motion, if there is that jiggling, then inertia it plays more of an effect of stretching and tearing of neuronal sheaths or neuronal bundles. And that's what these images show from diffusion tensor imaging, shows this tearing in the frontal areas. So both contribute to this fingerprint of traumatic brain injury being damage to the frontal lobes. And in particular, it's these connections of the frontal lobes into the from the midbrain into the frontal lobes. Now you might think this is a schematic of the effects of traumatic brain injury. This is actually the classic schematic showing the neuronal systems underlying addiction. And it is particularly these dopaminergic circuits from the mid up to the prefrontal cortex that are implicated in the sustaining of addictive behavior. And those are the very networks that are affected by a traumatic brain injury. And for humans, if you're going to pick a part of the brain to injure, the frontal area is not the one to pick. This is a bit simplified, but if we look at the kinds of functions that the frontal areas, the frontal lobes subserve, many of these are abilities that are critical to success in a complex society. Many of them are abilities or skills that we develop during childhood and are expected to have in adulthood. And indeed, the frontal areas of the brain develop the most from infancy to early adulthood. And in humans, the frontal lobes make up a higher proportion of the total cortex than for any other mammal. These abilities are critical, and when there are weaknesses, when they are affected, it's more likely that we're going to end up in some kind of trouble in society, including having a substance use disorder. But there's a double whammy here. And then if you look at, some of these abilities, these are also abilities that you need in order to address a substance use disorder. So not only does the injury to the frontal areas make you more susceptible to having a substance use disorder, it also then makes treatment for it, or the success of treatment for it, more difficult, because some of these abilities are affected, and they are the variabilities that we need to be able to succeed in substance use disorder treatment. I've been talking about traumatic brain injury. You may have noticed that, but there's a very similar picture for anoxic and hypoxic brain injury. And that, when the body, when you stop breathing, there's no longer oxygen going where it needs to go throughout the body. Those organs that are the biggest users of oxygen are the most affected. The brain is a hog for oxygen. And then there's certain areas within the brain, the hippocampus, the cerebellum, that are themselves big users even within the brain. And that's why we often get memory problems because of the hippocampus. We often get fine motor problems when there's anoxia or hypoxia because of the cerebellum. But we also get effects in this because of the medial forebrain bundle being a big user of oxygen and its connections into the frontal areas. So when you think about anoxia and hypoxia, think about overdose. Think about strangulation that occurs as part of domestic intimate partner violence. So traumatic brain injury is affecting these frontal areas, and anoxia and hypoxia also affects these frontal areas. And we're serving a number of populations who potentially have exposure from both. And just to make this point, here's this slide again, and I've got the anoxia and hypoxia and the traumatic brain injury highlighted because when we are trying to screen for, does this person have a history of brain injury that we should be concerned about? We don't want to miss anoxic and hypoxic events. We don't want to miss histories of traumatic brain injury, but we have to get at them differently. Okay, clinical implications. In my years of working in substance use disorder treatment, there were two clinical observations that I just kept coming back over and over again and being reinforced. And the first was that when you look at individuals in substance use disorder treatment, those with a history of brain injury, there's an even greater disconnect between their intention to change their behavior and successfully changing. Everybody has a disconnect, or we wouldn't need a substance use disorder treatment system, or at least as much as we have, because once you decided this is something I want to do differently, it would happen. But we all have a disconnect from wanting to making the behavior stable and sustained. But when you have a history of traumatic brain injury, that disconnect is more difficult. Getting there, getting to sobriety, and getting from sobriety to abstinence is going to be more difficult. The other persistent clinical observation is that those clients with a brain injury are more likely to prematurely discontinue treatment. And from the provider side, we often say, well, they're non-compliant. They are not showing up, they're not participating, they're a source of distraction for the other clients. So we consistently see that folks with brain injury more likely to be to prematurely terminate. There are a number of reasons for this. A couple just kind of from 10,000 feet or so is that the neurobehavioral impairments, including cognitive impairments that we've been talking about earlier, really undermine the ability to participate conventionally in treatment. Now, I don't believe that they need separate treatment. That's not what this means. What they mean is we need to be aware of their cognitive impairment so that we can make treatment accessible to them. First, what happens is that some of those frontal area effects, being more disinhibited, being more hyperverbose, being more impulsive, can, when they play out in treatment, they can be viewed as disruptive. And we're intentionally disruptive, that the person is doing this for reasons other than wanting to get better. And then when you combine that with not having a good sense of some of the social rules and being able to detect the impact of their behavior on others, it often becomes then a source of consternation for particularly fellow clients, if not staff. It's not unusual at all for somebody with a history of brain injury and cognitive impairment to end up being kind of the focal point of disdain or aggression or teasing or anything or all of the above from other clients, because they view their behavior as being as being intentional rather than being a source, a result of an injury. The other things that make it more difficult in treatment is that the cognitive impairment in itself actually makes some of the demands of treatment more difficult. We ignore sometimes that there is a cognitive load to our typical treatment. One, we use a lot of groups. Groups are more difficult than individual. They require a better ability to sustain attention and to benefit from listening to multiple, from auditory processing. Some treatment programs and or treatment approaches have a lexicon, a jargon that has to be learned. And that is more difficult just because of learning and memory problems than some. And to the extent that we use didactic training, meaning teaching, where it's lecturing, that is more difficult for people with cognitive impairment. So the cognitive load of treatment is something we kind of take for granted. We think that if everybody can, everybody's equal in their ability to benefit from this kind of setting, but people are not equal. And finally, the one that breaks my heart when we used to see it was that, and I've alluded to this already, that when a neurologic problem is misinterpreted by staff as resistance to treatment. And I cannot tell you how many times we saw this as we were working to try to get a person with brain injury involved in a treatment program, and a behavior like missing an appointment or talking too much in group or not seeming to participate in group, both ends of it, were viewed as that intentional, that won't, versus being recognized for what they were, which was that a person is having trouble, they can't do that. There was a study now, and I realize this is a little bit dated, but now 25 years or so ago, the MATCH study that was done, and its intention was to try to see which kinds of treatment work best for which kind of people. In the end, we didn't find that we could match them up. But one of the less well-known results of that was that this enormous study was able to look at how cognitive impairment then in some folks affected their course of treatment. And I realize this graphic is a little bit complicated, so I'm just going to say it, talk it out loud. And that's these individuals down here with cognitive impairment were more likely to have problems with treatment compliance. And that's the negative, the dotted line means it's a negative relationship, not a positive relationship. But before they actually dropped out of treatment, what could be detected was that they started to lose confidence in the likelihood that treatment would be efficacious for them. They started saying things like, I think this may be a good program, but it's not going to work for me. Or, these other people may benefit, but I don't think I'm going to. And that loss of confidence then would precede dropping out. So it's my belief, though this study wasn't able to confirm that, is that that lack of confidence is there a reflection or a detection on their part that they're not quite fitting, that that this milieu, this approach it doesn't get them, and that the cognitive impairment, I believe, is often a source of that. So, if we're going to do neurologic informed care, if we're going to know when this is an issue for someone, how would you know as a professional staff person? There are medical tests. We have imaging, and we have blood biomarkers for some detection of history of traumatic brain injury or other acquired brain injuries. But the problem is that, one, let's start with expensive, not easy to get to, but also in terms of imaging, the tests we have, if they say yes, you appear to have had an injury in your past, it can be believed. But if it says no, there's no signs of it, it should not, that doesn't mean you haven't. So a yes is a yes, but a no is a maybe. Blood biomarkers are kind of the reverse of that. One, they have to be done within hours of the injury. We don't have any blood biomarkers that can be used many years post at this point. Maybe those are coming. But right now, that's kind of a no is a no, but a yes is a maybe. So they're not both sensitive and specific, as we say in the screening world. But what about performance tests where we actually test for cognitive impairment? And of course, the ones we know most about are neuropsychological testing. Neuropsychological testing, one, is also expensive, hard to get to, et cetera, so not a practical solution. But furthermore, is like imaging, in that if you have deficits apparent in neuropsychological testing, you can trust that a yes is a yes. But a clean neuropsychological test does not mean that you have no limits, no functional cognitive impairment that still might be affecting your ability to learn. They're just not that sensitive, particularly in real world cognitive function. Neuropsychological testing is done in a very pristine environment. The idea is to get a person's best performance. But those weaknesses that interact with the environment, when it's noisy or when you're tired, are not going to be detected. Well, there are cognitive screeners, and the ASAM chapter does talk about cognitive screeners. But as any neuropsychologist can tell you, that cognitive screeners are kind of even worse in terms of having false negatives. And in our years of running a brain injury and substance use disorder program, we always did cognitive screeners, and it was really hit or miss where they ever detected any cognitive impairment. If somebody had a very severe injury and very severe functioning, yes, they caught it. But otherwise, often they showed no source of deficit. So despite the fact that the ASAM chapter talks about cognitive screeners, I don't think it's a good solution. Other ways to detect are from the person's own self-report. One of those is just their medical history, medical and injury history. That's where I've spent a lot of time in development of a method for systematically getting at prior history of traumatic brain injury, but you can also ask about prior medical history. And some of those events that are more severe, like a severe stroke or a tumor being removed, you're going to be told about. And then your antenna can go up and you can say, maybe there's somebody there, this is somebody I need to be concerned about their cognitive impairment. The other thing you can do is you can just ask them about their cognitive impairment. You can say, do you have problems with your memory? Do you have problems with attention? It's not, neither of these are foolproof by any means. And I think there's something to say for combining them. People may not be aware of all the ways in which their cognitive function is being affected. And so you do get underreporting. And finally, there's observation. The problem is that we're not being, the substance use disorder treatment workforce is not being trained to look for cognitive impairment, and particularly the subtle cognitive impairment. And so, that may be something in our future where we can use observation more than any a standardized method, but we are simply not there yet. And there we go. So I said I was going to mention a product that the National Association of State Head Injury Administrators has developed. It's called the Online Brain Injury Screening and Support System. It combines a self-report of medical and injury history, and this is where it uses the methodology we developed at Ohio State, the OSU TBI identification method. It's been expanded to include asking about other acquired brain injuries. But the OBIS, as it's called, also then has a symptom questionnaire, the symptom questionnaire for brain injury developed in Colorado, that gets at the actual self-report of problems, regardless of etiology of problems. So it does both. It's self-administered, meaning it can be the individual, upon being set up, can do it online. And if it's positive, it goes on to identify challenges and suggest strategies that may be useful for that person in terms of compensating or accommodating the resulting weaknesses. And then it also provides whoever set it up, treatment staff or whomever, screening staff, whoever set them up for the screening, it provides that person with the same information, all of which is emailed as the typical way in which the information is shared. So, the idea is to try to get something that's more usable into the hands, and this isn't just being used in substance use disorder treatment, it's being used in lots of different settings. But in terms of doing neurologic informed care, this gives us an opportunity to more readily screen so that we know this is somebody that we need to be thinking about. How can we accommodate their cognitive weaknesses? I'm going to wrap up here with just a comment about observation. I already said it, that maybe we can evolve to where it's just part of the lexicon of everybody, all of our treatment staff, that this is an individual difference, just like trauma, that we've learned to look for and have some idea about how it's playing out in the treatment setting and in this person's life. We have been working on a pilot project in 2 substance use disorder treatment programs here in Ohio, where we're saying, what does it actually take to institute neurologic informed care in the agency? And one impression I have, I'll just share with you. This is really on the impression side. I'm not 2 years from now, I may deny all of this. But what we're seeing is 3 areas of cognitive weakness that seem to be particularly relevant and aren't already a part of the lexicon and skill set of the treatment staff. And that's attention span and limited attention span, particularly when using group interventions. Reading ability, we're relying a lot on workbooks and other things that require reading, and we're not necessarily checking. We may be aware of complete lack of literacy, but we're not checking whether reading is a skill that a person has for gaining new information. And then auditory retention or new learning when it's through things spoken. And these 3 areas, there's a lot of cognitive functions and domains, a lot of weaknesses, but if every, substance use disorder treatment professional was looking for these 3 and thinking about it and thinking about how they can overcome a client's weakness in these 3, we would make major strides in our treatment. So neurologic informed care is it's a knowledge and skills to make all substance use disorder treatment accessible to people with cognitive impairment, and particularly being able to detect those with the more subtle cognitive weaknesses. In the ASAM chapter, we go on to describe neurologic responsive care, where this awareness is really being woven into the fabric of the agency. So, we're doing systematic screening at the front door as part of the admissions process. We've thought about how our groups are conducted, how long they are, how many breaks we'll have, where they're being conducted, and is it a distraction-free environment? So we're thinking ahead and thinking about how cognitive impairment is playing out in our entire program. And then neurologic specific care then is taking this knowledge and taking the accommodations we made in the program, and on an individual basis saying, this person coming through has this particular weakness. I'm going to do these things, these accommodations, to make their substance use disorder treatment more accessible to them. So just to wrap up, cognitive impairment due to brain injury is common in persons with substance use disorder treatment. This is not a one-off. This is in a good proportion, a substantial proportion of the people we're treating. It does present unique clinical issues that we may have been overlooking, and thus contributing to some of the dropout rates that we see. And thus we need neurologic informed care to try to counter that. Each behavioral health professional, substance use disorder treatment professional, needs to be capable of identifying when there's cognitive impairment. I'm not talking diagnostic, I'm talking observationally, being able to see it, either that's through screening, formal screening, or becoming aware enough and looking for it such that it is integrated into how you treat individuals. And then having seen it, to have some skills, some ideas in your back pocket for how do you accommodate a short attention span. Well, this is somebody I'm going to make sure I debrief with them right after group to help them retain or capture the major points I wanted them to capture from group. This is somebody in this residential treatment setting that, even though we don't allow them to have a cell phone, I'm going to give them an alarm that's not connected to the internet that will make sure that they are establishing a routine in the morning so they can get up and be ready and not be late for group, those kinds of accommodations. And then finally, what we would hope is that the entire behavioral health field will evolve toward this neurologic specific care, meaning we can count on the fact that each individual who comes through the door is going to be recognized for their individual differences, including differences in how they process information, and that won't be a barrier to treatment. So that is all that I have for you today. It looks like we have 2 minutes before the hour, so.
Loads and loads and loads of comments, Dr. Corrigan, in the chat, and a few questions. I think you have touched on the answers for most of these. I did see a question related to advocating for more extensive kinds of testing for insurance to cover, which I think is a great point, particularly in this space.
Absolutely. I believe that screening can be done relatively cheaply, although everything requires time, and we realize that everybody is being asked to do a lot of screening. But sometimes you need more. Sometimes there's just that person that you can't figure it out. And yes, being able to use insurance for what it's meant for, healthcare problems would be great.
So though we know we need to do that kind of advocating, I think this is a pretty huge step in the right direction, for having more inclusion related to brain injury in the addiction field, for sure. So much appreciate what you've shared. And I know we're almost at the top of the hour, and Terry wanted a minute to wrap things up. So thank you.
Thank you very much.
Terry, you're on mute.
Thank you. Thank you, Dr. Corrigan, for such a great presentation, and for everyone for joining. We just want to do some evaluation questions here at the end. They're useful for us as we plan for future evaluation, future webinars, and then to see what we can improve upon. And as always, you can reach out to us if you have any questions or answers. We will post in a few weeks the recording on the ACL website, but within 24 hours, you will get a link from Zoom. It's just not, it's the one posted on the ACL website is the more complete. And please reach out to us, and thank you so much. And we are really hoping you will join us soon. We'll have our next webinar in August, and we'll be sending out information in the next week about it. Thank you, and have a good day. Take care.